Well, thank you for getting up so early. I bet the traffic was really good for you guys, better than normal. For those of you that are just starting and don't know me very well, my name is Heidi Roy-Slamke. I'm a licensed veterinary technician. I graduated from Michigan State University a long time ago, but I basically have a VTS in anesthesia that I got in 2003, and I was part of the organizing committee for the Academy of Veterinary Surgical Technicians. We gave our first certifying exam in 2013, and I also got the fear-free certification that I know all of you guys are going to be doing, if not so already. But I'm a big old nerd. I'm a gas passer and a drug dealer and a slicer and a dicer, and this is my fun. So I'm just going to go over the OVRS anesthetic machines. Luckily, we only have basically 3 different kinds, but I'm going to go through the 2 most common ones that we have here, and then the one in CT. If you have any questions about that, you can certainly let me know. But what I like to do is stress that whenever you meet a machine that you're not familiar with, take the time to follow the flow of gas through it. I think that really helps instill a lot of confidence in how it's working, and I'm going to give you some tips on how that usually goes. We're going to talk about what each component does and make sure that you understand how to do a leak test, which should be done whenever you change a soda sorber, really mess with the integrity of the machine. We'll talk a little bit about troubleshooting, the care and feeding of your machine, and I'll show you how some of that stuff works at the end. So the only one that is different, Blue and EVAD. EVAD is Dave Schwager, who spelled his name backwards to come up with these. We have a lot of these around the hospital. The platform may be a little bit different, but essentially the function is going to be the same. This Blue was made by Steve Boggs, and it is very similar, even though it looks a little bit different. A couple of big differences for this EVAD Blue machine down here is the active scavenger interface is completely different than the other ones that we have. Most of our active scavenger interfaces, there's this blue bag down at the bottom that has a stick in the bottom of it, and the bag will not work unless the stick is in there. This is the only one that has a bag on it. There is no stick on it, and there actually is a slightly different active scavenger on there right now because we were having a lot of trouble with it, as some of you that work in ER and went to OR1 found out. So take a look at that one when you get a chance, and if you have any questions, let me know. We also have the matrix machines, which is where some of the diagrams come from in this, and then this one DRE machine that's in CT. I like you to follow the flow of gas through these matrix machines and these EVAD machines because everything's just out there flopping in the breeze. When you get to this DRE machine, some of the flow of gas is top secret, meaning you can't just take a tube and follow it along and find out where it goes. So when you get to this one, you have to sort of go by how you know they work and the order of things versus these other machines. Also the big difference too, when soda sorb and the carbon dioxide percolates through the soda sorb canisters on most of these machines, it's percolating from the bottom to the top. This DRE is the one that actually percolates from the top down and actually gets a majority of its color change on the top, and that's probably one of the bigger differences in the flow of gas through that one. So the matrix machines, and these are the big ones that we have in like OR2 and OR4 in one of the x-ray rooms. The first stop is always going to be the flow meter, and the oxygen comes in here. And then and the flow meters, you always read the center of the ball or the top of the float. But they only go to 4 liters, and when you open those flow meters, you can actually hear the oxygen coming on. If I had a flow meter that went all the way up to the ceiling, the more I open that needle valve, the more oxygen that goes through there. So you turn it on, initially you might not hear it, and then it goes shh, and you can hear how much faster the oxygen comes out of that flow meter when you open that needle valve. I will also tell you we've been having some problems with some of these needle valves leaking, specifically the one in the small x-ray room. You might notice a bright purple color on the top, and I'll show you that actually is a sign from the soda-sorb LF that the oxygen either was left on or that needle valve is leaking. Once you get through the oxygen flow meter, the next stop's going to be the vaporizer, and there's usually clues. You can look at the top of your vaporizer and you can see oftentimes it will say inlet and outlet, or there'll be an arrow pointing which way the flow of gas flows through there. And so the only purpose of the oxygen is to carry that anesthetic molecules and carry those gases through. So the higher your oxygen flow rates, the more anesthetic molecules you can pick up, and the faster your plane changes are going to occur. And this makes sense to me. You know, if you're trying to fill your sink and you have your water on a little trickle, it's going to take a lot longer to fill that sink than if you turn that water on full blast. So fast plane changes, we're going to always want to turn our vaporizer setting up and turn our oxygen flow up. And then it's going to come out here. The matrix machines, it's going to go to the patient on the inspiratory side. And then when the animal exhales, it comes out this expiratory limb. It comes right down through this tube, again percolates from the bottom to the top with the carbon dioxide scrubbed out, and then rejoins the cold, fresh incoming gas, which is why the system is called the circle system. I will also tell you that I really I'm not a big fan of these matrix machines, and the reason for that is most of the time whenever you meet an anesthetic machine you're not familiar with, you're going to be able to guess that the bag is on the expiratory side. But for whatever reason they decided to make the bag go on the inspiratory side of these machines, and that's why when you look at one, they're labeled really, really thoroughly that the bag is inspiratory, the other side is expiratory, because it's counterintuitive to the vast majority of machines that you will find out there. So that is the flow of gas through the circle system. When we go ahead and hook up our non-rebreather, we're still always going to have the oxygen being the first stop, the vaporizer being the second stop. And then with the non-rebreather, you can actually take the soda-sorb assembly off like I could with this machine right here. I can put it in another room. So I'm not scrubbing out carbon dioxide at all, which is when we talk about these little tiny animals that we're using these non-rebreathers on, we're bypassing all of those flutter valves. Think about this. If you had a little teeny tiny tidal volume, maybe you're a 12-ounce kitten, and you're making 10 to 20 mLs is your whole tidal volume breath size, you're not going to have enough force or have enough breath size to be able to move all of these flutter valves and all of that. And so when we use these non-rebreathers, we're decreasing resistance to breathing, but we're also not scrubbing out carbon dioxide. So you can see the inhalant and the oxygen goes right to the patient. They inhale, they exhale, it goes into that bag where you can watch it breathe, and then it goes into the scavenger. So, and those flutter valves, if you look on these machines, if they've been being used for a really long time, you probably notice that there's a lot of moisture that can even set right on top of that flutter disc. And every time there's a lot of moisture in there, that is also going to make it harder for any animal to move that flutter valve and to breathe. So it's important, if you see moisture sitting on top of those discs, that you take it apart and take the time to clean those out and dry those out, which would be more of an issue on the matrix machine in the operating room. So the oxygen supply, if we have the H tanks, which we used to use, there's always going to be a manifold pressure and a line pressure, and that's because anesthetic machines cannot use the pressure that's right out of those H tanks. We have to take that down to about 50 to 55 psi. These little E tanks, some of our E tanks have 2 valves on them. Most of them only have 1, where the actual 50-55 pressure reduction is being taken care of right in that manifold there. And then there's a math problem that you guys can do, 0.3 times the PSI to find out how much oxygen is in your tank versus for the H tanks 3 times the PSI if you ever want to figure out how much you have left in those tanks. Here at OVRS now, hopefully you've taken a look in that closet. It looks like a hot water heater. They're liquid oxygen because we were just going through so much of that. So you always want to use the appropriate flow rates, because does anyone know if I went to use this anesthetic machine right now and I, filled up all the nooks and crannies and conduits and all that, if I cleared out that soda sorb and filled water in there, there would be about 4 to 6 liters of water that I would use to just fill up all of those tubes and conduits and spaces. So if I was going to use that machine right now on an animal, what is in that machine right now? In this part right here? Anybody? I know it's early. What are you breathing right now? Room air. So yeah, so there's room air in that 4 to 6 liters of space. So whenever we first hook our animal up to that, we need to push all of that room air out and get that concentration to what we have set on our vaporizer. So if I have my vaporizer set at 4% because I want the animal to go down, then I'm going to have to turn the action flow rates up and leave my concentration at 4% in order to get all of the nooks and crannies and conduits and all of that full with my 4%. And this makes sense to me, but you see how much higher the non-rebreather circuits are? 200 to 300 mLs per kilo per minute, because again, we're not scrubbing out carbon dioxide. We're using high gas flows to push the exhaled carbon dioxide and waste gases into the scavenger. So that's the big difference. Induction versus maintenance, this is exactly why we use different flow rates for induction, because I'm trying to clear room air out of those conduits versus once I get to maintenance and my animal's not light anymore, then we can get away with lower inhalant concentrations. So if my animal all of a sudden is starting to move and trying to leave, the first thing that I'm going to do is I'm going to increase my vaporizer setting to maybe 5% while hollering for propofol, right? And then I'm also going to increase my action flow rate, and then I'm going to bag for that animal so that I can get them back down. Can anybody tell me why an anesthetic machine might be called an intermittent dosing device? Intermittent dosing device. Do you guys have any idea?
They're only getting it when they inhale?
Yeah, so I have candy, so you're a smarty. So yeah, so they're not getting their dose the whole time they're on it. Just because the machine is turned on, they're only getting good doses of their drug when they're breathing in and when they're breathing in well. So that's why you can anticipate if you have an animal that is panting or taking a lot of little teeny tiny breaths, that animal's probably not getting good doses of its drug and maybe started to wake up. And what do? You bag it down, and then you're going, so then it goes to sleep because it just got really good doses of its drug, and then it's not breathing well again, and then it starts panting again, and then you do this again, and you get these roller coaster cases, which is when I would choose to just hook it up to a ventilator if I get these really challenging cases like this. So I already told you guys, read the center of the ball or the top of the float, and really be careful. Don't over tighten these needle valves, especially that machine in CT, that DRE machine. It actually has many turns that it goes once the float is down, but you really only have to take it to the float is in the down position. You don't have to keep turning it and turning it and turning it, as these do break fairly often around here. Now you have to replace them. You can do low flow anesthesia because we are measuring inspired and expired carbon dioxide. So when you get that little bitty guy and you're using side stream technology to measure carbon dioxide, because of sample dilution, because of the 200 to 300 mLs per kilo per minute, these high oxygen flow rates, and how much carbon dioxide is that little 12-ounce kitten going to make? Not much at all. So you might not see a lot of carbon dioxide coming out on your waveform, not the normal 25 to 35 that I would expect. You can always try to turn down your fresh gas flows to minimize how much sample dilution to hopefully get a little bit higher of a carbon dioxide number. It might not ever be 35 to 45, but some of those little bitty guys, I'm happy to see 10 or 20%, or 10 or 20 millimeters of mercury, because then I know they're not dead, right? So they're making carbon dioxide, they're alive on you, so that's good. So one of the things about the oxygen flush valve is you completely bypass the vaporizer and you're blowing 30 to 60 liters or more per minute. And some of my VTS anesthesia colleagues, we talk about this. Some of my friends don't use the oxygen flush ever at all. For me, it really depends on the machine. Now, if I'm trying to get the animal to wake up, I may push that depending on the machine. Some of the oxygen flushes on some of these machines, I call them real pansy flushes. And we'll try this one here. So you push it and it goes like, right? There's not, any good blast of gas through there. But there are some of them, when you push it, it goes, and like you can feel like this huge blast of gas. So you do have to be really, really, really careful. I don't use the oxygen flush on every machine because some of them I do worry about barotrauma and blasting a lot of oxygen through those. So the most important thing I wanted to make clear to you guys is that you bypass the vaporizer. So it doesn't make sense to me to run the oxygen flush when I'm trying to knock something out or get rid of the room air, because once you push that, you're diluting out the entire gas concentration you have in there. And that is why I would really only use it when I want to get rid of the gas in there and try to wake the animal up and get rid of whatever concentration I have in there. Does that make sense to everybody? Not at 6 o'clock in the morning. No? Does it not make sense to anybody else? I'll try to, yes, everyone gets it? All right, great. Because I don't teach rocket science. When you really stop and think about this, this makes sense to me. So when you first hook your animal up, you don't want them sucking rubber, right? So your bag will be flat, right? That's called sucking rubber. When the animal's breathing in, I'm trying to get it down to 3% or whatever I'm trying, my vaporizer set at. I turn my oxygen flow up until I fill my bag so that when that animal is breathing in, that it's actually getting a dose of the percentage I have dialed on my vaporizer. And that's why I won't use the oxygen flush to fill it up. Okay, so with the non-rebreather, can anybody tell me something that you should never, ever, ever, ever do with a non-rebreather? Hit the oxygen flush, yeah. I have a star in the front row. Yeah, so you never ever want to push the oxygen flush. And some people will put a piece of tape over it or something like that, because if you want to pop the little guy, you blast 30 to 60 liters or more of oxygen to these little bitty guys. So yeah, you should never, ever, ever push the oxygen flush. So there's actually a math problem that we can figure out how much of these liquid inhalants we're going through. Basically, it's 3 times your percent of oxygen times your vaporizer setting. So if you were doing, say, 2% at 2 liters a minute, you would be doing about 12 milliliters an hour. And then as far as the vaporizers go, we do have a couple different types of vaporizers. Most of the time, on the bottom here, there's going to be a little hole. And that actually is where you would drain out your liquid anesthetic. Every now and then, the one in CT will start dripping liquid out of there, so that's not cool because that's actually isoflurane coming out of that hole. A lot of times, the cap to this is actually the key. So if you pull the cap up, flip it upside down, you can tighten that up so it's not leaking, or you can call me and I can do it. But most of the time, these vaporizer caps do serve as a key for in there. Always wash your hands after you handle liquid anesthetics because they can get absorbed through your skin. So even if you're filling the vaporizers at the end of the day, just make sure you wash your hands after that. And then the one machine in OR1, the blue EVAD machine, you do have to be really careful when you activate the dial on the vaporizer that you push the button down here first. He wants you to use 2 hands, push the button, and then open it. We actually already had to have a repair done on that because this got bent and the vaporizer wasn't really working properly. So do be careful about that. Some of our vaporizers do have 2 windows. They're kind of bigger vaporizers. So you do have to check both sides to see if the one side is full or not. It does get a little bit tricky. You sometimes have to jiggle it to see if you can find where the fluid level is in there. And does anybody know what degrees you cannot tip a vaporizer? So I put here, all vaporizers must remain level to function properly. Does anybody know how far you can tip a vaporizer before you have to have it serviced? It's real nerd information. 45 degrees. 45 degrees. So if for some reason somebody tripped and fell over that machine and it landed on the ground or it got tipped more than 45 degrees, whatever you have dialed on the vaporizer won't all of a sudden be accurate. So you might have 2% dialed, they could be delivering 5% or 0%. And so if that ever happens, let me know, because the vaporizer has to get drained and dried out. There's a wick in there, or it would have to go out for service. Here's one of those double chambers. So they actually have two windows. The lower window is where the refill button is. The upper window is where it says full. And you know, I don't recommend that you overfill these, because if you're trying to fill this to the tippy top, and you have this cap open, what's going to happen is the liquid's going to come out the side. And to be honest, if you can smell your inhalant, you've already exceeded the amount that OSHA wants us to be able to smell. You're smelling more than 50 parts per million, and they really don't want you to smell more than 2 parts per million, which you wouldn't be able to smell at all. Okay, so when you're filling the vaporizers, it's really important that like you wear gloves and then wipe around the rim of here, because you don't want to pour toenail shards, dust, anything like that into those vaporizers. And in fact, when you look in those windows, they should always look clear. So if you ever look in there and you see the liquid looks yellow or discolored, we would want to service those vaporizers. And for this one, this little screw cap right here, this is actually how you drain the vaporizer, and then there's a little hole down the bottom there. So this one isn't necessarily using the cap as a key. This one you just hand screw this little circle right here. And then always use these filling spouts and don't throw them out. We don't have a lot of them, but truly it's impossible to fill these vaporizers without the filling spout, without filling it all over the darn place. Or maybe it's just me that cannot fill the vaporizer without these filling spouts, but they do make it a lot nicer. This is where the gas lives, down here in the right cabinet in the bottom, over by the dirty table. Okay. And so one thing I want you guys to know about the soda sorb around here is that most of the time in most of the machines we have the soda sorb LF. And that soda sorb LF lasts a lot longer than the other stuff that you guys use for your incubator or your special stuff in critical care. But whenever you fill that, you do want to make sure you fill that to within an inch of the top. And then I also do try to jiggle those canisters and to prevent channeling, because it is conceivable that the carbon dioxide would percolate through there, find a path, and be able to come back into the rest of the circuit without having the carbon dioxide scrubbed out. So you do want to make sure that you don't overfill it or underfill it. We always keep the unsealed or the brand new stuff in a sealed container, so you don't want to leave that out to room air. And you know, this makes sense to me. So if I was doing a week of cats, and I had 30 cats I was going to do all week long, we're going to spay 30 cats one day here, or I'm going to do 4 hours of a 200-pound Mastiff, anesthesia for 4 hours. Which one of those cases do you think would use the soda sorb up faster? 30 cats or my 200-pounder for 4 hours? You can just...
I'm going to say Mastiff or your giant.
Yes, and I'm going to throw some candy at you, yes. And I may hit you in the head. Okay. Okay, that was a terrible shot. So yeah, and this makes sense to me, right? If you're doing these cats, you might be using non-rebreathers all week. And think about the tidal volume, or how much carbon dioxide, you know, the cat is breathing out with every single breath. It's very small. Versus if I have this 200-pounder, you know, yes, moisture is a side effect. Water is a side effect of the chemical reaction that occurs when the sotasorb is working, but respiratory losses can also decrease the efficacy of your sotasorb. So it is conceivable that that 200-pound Mastiff, I might not be able to finish all 4 hours of that case before I might need to change the sotasorb, or I start seeing increased IN, inspired carbon dioxide, and increased exhaled carbon dioxide because the sotasorb is exhausted. So whenever it gets really, really wet, and especially when you guys in critical care are doing some long-term ventilation with that DRE machine from CT, you do want to make sure that the sotasorb doesn't get overly wet for, like if you're using it for 12 or 24 hours, you might have to change it more often, absolutely. So this makes sense to me, and that's why the sotasorb around here, we really, you know, only change it when it starts to change colors by a two-tone, which I'll show you. I find the little color charts that are on those stickers, I find them completely useless, as I told Andrew recently. So, yeah, this makes sense to me. I will also tell you, if you're ever in a case where maybe the sotasorb does look like it's expired and your expired and inspired carbon dioxides are going up and up and up, what you can do to get through the case without having to change machines or change the sotasorb in the middle of the surgery is just keep turning the oxygen up. Based on how many liters per minute until those numbers come down. So essentially what you're doing is you're turning your circle system into a non-rebreathing system like I do already for the cats. So instead of the sotasorb being asked to scrub out the carbon dioxide from those bigger animals and the exhausted sotasorb, is we are just pushing it now into the scavenger, and we don't really use the sotasorb anymore. So you can always do that to band-aid your case until you get through that one. So here is when, at OVRS, when I change the sotasorb. Now this is the bottom of the canister right here, so I know for most of these, the gases going through there are percolating from the bottom to the top. So when I start seeing two-tone pellets down here near the bottom, this is when I will change it. When you pull off that sotasorb canister, this is what it looks like on the top. And then this is actually not exhausted sotasorb. This is what happens when the LF is exposed to oxygen. So on that EVAD machine, you know, the oxygen's coming right up through here, the path of least resistance, it settles right on the top. So this indicates the pellets are a little bit desiccated, but I don't always change it when that happens because it's not exhausted. So this is how I know when you guys leave the oxygen on. And now you will know too. You'll be able to look in and see purple on the top, somebody left the oxygen on, or there's a problem with that needle valve. So these one-way flutter discs are designed to prevent backward flow of gas through these machines, and they're nice because they do let you observe how the animal's breathing. So, you know, usually they're going to be alternating. One disc will be going up while the other disc is going down, and they do have to sit flat over those holes here. And every now and then we have a flutter disc that gets warped, and we'll also let carbon dioxide go carry around in this circle. And we actually had that happen not too long ago with that new blue machine that we got. But you do, again, want to make sure that there's not a lot of moisture in under these domes, and certainly that there's not moisture sitting on top of that flutter disc because, again, that will make it harder for that animal to move that flutter disc during its breathing. Now we do have some of these negative pressure relief valve, and where these came from, does anybody go to the dentist and get the gas, the nitrous gas, nitrous oxide? So in case the dentist ever forgot about you while you're all sailing in your chair at the dentist and they ran out of oxygen and they ran out of gas, this negative pressure relief valve would let you not die in the dentist chair, so that should be very comforting to you. What it does is when it senses negative pressure in the circuit, so sucking rubber and the animal's trying to breathe, it actually lets room air in to the circuit. So that's the only thing these do. I will tell you sometimes these can be associated with leaking or leaks, so they're not always replaced with the same negative pressure relief valve, but that's all it does is it just draws room air into the circuit when it senses negative pressure. And this is how it works. There's a little diaphragm in there. It'll deflate the reservoir bag first, and then the diaphragm opens up and it'll pull room air into there. So these are unique to the matrix machines. The EVAD machines don't have this on there. Okay, and then these are the bags and hoses that we use most often at OVRS. And truly, the size of your Y hose is dictated by the maximum diameter of your endotracheal tube. And this makes sense to me. If I don't want to cause a lot of resistance to breathing, the diameter of my endotracheal tube needs to be at least the size of the Y hose that I'm putting on. So you would never want to put a large endotracheal tube in and then put a Y hose on that was smaller than the diameter of that endotracheal tube. But in general, the really, really big hoses, these are for 90 pounds or greater. When you see the blue F circuit, these are for 45 to 90 pounds. These teal ones here are about 15 to 44 pounds. And then we use these non-rebreathers for basically if the animal's breath size is too small to move the flutter valves. That's when push comes to shove and you must use one of these non-rebreathers. Has anybody read the 2018 AAFP feline anesthesia guidelines that I have emailed to the staff several times over the last 6 months to a year? Has anybody read them? I try, people, I try. Okay. Okay, and that doesn't count. So in there, if you want to know about exactly what mechanical dead space in there, it talks about that. And it talks about that 3 kilograms is 100%. They say if your animal's less than 3 kilograms, you really should be using a non-rebreather. The other sizes of animals, it's not as important to do it like the 15-pounders. But I will tell you, Dr. Jeff Coe, who's a board-certified anesthesiologist, he uses the non-rebreather when you want to mask something down, and we frown upon that here because masking and boxing is very stressful. But truly, all you want to do is you want to blast gas to the animal's face and take it away in your scavenger. And so that, does make sense to me that using a non-rebreather would be an efficient way to mask down an animal, because you really don't need the soda-sorb assembly. You're not really trying to scrub out carbon dioxide or anything like that for those. And then the bag is 30 times the weight in pounds. And let's remember, people, that this is based on lean body weight. So if I suddenly became a 500 pounds, I don't suddenly have the lung capacity of a pony, right? I still have the lung capacity of, I go with 125, okay? So you calculate my lean body weight, and that's the bag size I should be using. And so is it an awful catastrophe if you use Y hoses that are too big for the animal's size? The downsides is that it's going to take gases longer to equilibrate because we're filling space we don't need to fit. And it's going to be longer for plane changes because, again, I'm filling space that I really don't need to fill with oxygen in my gas. So everybody with me so far on these 90 pounds or greater? This is what they use on people, I'm sure. And these F circuits do have to be hooked up in a very specific way. Let's talk about our reservoir bag. Bags are nice. Again, you never want them sucking rubber, but you do want to make sure that bag is big enough that you can give a nice breath. So that is why when you're torn between two sizes and you do that calculation, you're always going to round up and choose a larger bag. So we can see if the animal's breathing or panting and know if we're in for a roller coaster case, or we can give a breath. If the bag is overinflated, your oxygen flow might be too high, or maybe your pop-off is a little bit short. Underinflated, the oxygen is too low, or there's a leak in the system somewhere. But again, even when I first took them up, I don't want them sucking rubber. That's a big no-no. The adult circuits, so 22 millimeters for patients more than 7 kilograms. We talked about that. But the circle systems are going to be associated with longer plane changes, right? Because I have to fill this 5 to 7 liters worth of space and, turn my oxygen flow up pretty high in order to make a rapid plane change versus my non-rebreathers. All I'm doing is blasting gas to their face and taking it into the scavenger. And so we're going to see much more rapid plane changes. What else is going to happen with a non-rebreather? You guys have seen the ice chips on the outside of this liquid oxygen tank. That means these cold, fresh oxygens are also going to be more likely to make these little bitty guys really cold or hypothermic, so we'll have to really keep an eye on their body temperature. The other thing I wanted to make sure you guys understand with the F circuits, that they're called a coaxial design. The fresh gas flows are coming in through the center tube here, and then the exhaled gases are going around the outside and through this elbow. So they do have to be hooked up in a very, very specific way, and I'm going to show you guys how to find out what is the inspiratory side of the machine if you don't know. We're going to put a bag on, we're going to push the oxygen flush, and then whatever side the blast of gas comes out of, we're going to know that that's your inspiratory side. But they do have to have the oxygen and the gas source has to be coming through this inner tube here. And then theoretically, the animal's exhaled gases help warm the cold, fresh incoming gases, which is what's up with this particular design. So non-rebreathers, for the little bitty guys, we don't have to move these flutter valves. They're inexpensive and lightweight. We get a real fast plane change. The doctor has no idea how to hook them up, so it's job security. Oh, except for Dr. Matisse, now she'll be the only one that knows how to do it. The downside is because we're using high flow rates, these guys are going to get cold. We're going to use definitely more oxygen and more inhalants. And we do have to be careful that we don't ever do oxygen flush because we can cause the barotrauma or popping of the lung. And then I put here lax pressure manometer, which a lot of the circuits we used to have around here did not have a pressure manometer, but the new ones, these safe size from Vetamac, I hope that's all you're using in your department. If you're not, let us know. They do have a little pressure manometer that I've been able to get some free samples of. That's why they all have my name on them. So the pressure manometer, this is going to tell us what the pressure is in the circuit. The biggest thing is where this says on the dial. If you ever watch a ventilator breathe, you actually see the hoses kind of stretching a little every time we're putting the positive pressure in there. So just in the back of your mind, know that the pressure here is going to be different, slightly different than if I follow it all the way down to the animal, just because of the changes in pressure that are occurring from the hoses and all stretching. The millimeters of mercury is not the same as centimeter of water. There is a math problem you have to do, but all of our pressure manometers are measuring in centimeters of water. And we will want to do this when we're checking for leaks. If any of these needles are not ever at zero, I do know how to fix that, so let me know. So this is all we have around here now, the safe side with a pressure manometer. This is actually the pressure manometer right here. It basically is very simple. You got green for okay, yellow for caution, red for don't do that. And the non-rebreathing Baine block for the little bitty guys, we have this official system here if you're going to be doing case for a while. It's still a non-rebreathing circuit, even though it has a coaxial hose design on it. But it has a nice pressure manometer. We can actually hook this up to the ventilator, and I can show you how to do that if you're interested. Here's a little video on how to hook that up.
Okay, I am going to quickly demonstrate how to hook up the non-rebreathing Baine block. These are for animals that weigh less than 7 kilograms or approximately 15 pounds. This hosing is specifically labeled non-rebreathing circuit, so it is dedicated to this Baine block system only. And it also clearly says on the edge of the tube here that you cannot use the carbon dioxide dead space adapters on this unit, because if you look carefully at the outlet, the gas comes out of the hole in the very center. And when you examine the endotracheal tubes that have the dead space adapters on them, you can see that there would only be room for the animal to inhale, and there would be no room allotted for the patient to exhale. So you would not use these on the Baine block. To hook the Baine block up to an anesthetic machine, you would insert it into the blocks on the dedicated anesthetic machines for these non-rebreathing Baine blocks. Then you will remove the tube where the oxygen and gas come out of, and you will insert it onto the Baine block at this location. Once you have securely seated the clear hose, you will remove the scavenging hose along with the pop-off, and you will place it onto the pop-off valve for the Baine block. Now you see you have created a non-rebreathing system where you can measure pressures, and you can quickly give a small breath, and you can shut the pop-off if you so desire and open it back up. And that is how you properly attach the non-rebreathing Baine block to an EVAD anesthesia machine. The setup will be similar for the Matrix machines.
Yeah, so if you ever are going to be in it for the long haul, maybe eyeball people are going to be doing a little bitty animal for a while, I would just hook that up instead of using the non-rebreathers that we have. Any questions on that? Okie dokie. So the Baine blocks, there's these extra little blocks that they put on there. There's the OR1, OR2, OR4, X-ray 1, and pre-op for the anesthetic machines that will take that Baine block. Okay, the adjustable pressure limiting valve, or the pop-off valve. Basically, you know, this is how we check for leaks. This is how we potentially give a breath, but I'm hoping now that all of our machines have the quick pop-off and that you guys don't do this routinely, because I worry about you getting like carpal tunnel, because you got to turn, give the breath, unturn. So pretty much all of our machines do have a quick pop-off on them. I will tell you though that if this is shut and you try to use your machine, you can kill something, which is why these new blue sections have shown up. These positive pressure relief valves have shown up on all the machines. You're not to ever take them off. And I will show you how it works if somebody did leave the pop-off shut on you. But fully open, they're technically supposed to stimulate nasal resistance, keeping a little bit of pressure in there, 1 to 3 centimeters. It's pretty minor. Now, I will tell you too that our Matrix machines do have this quick pop-off here, and this one also lets go at 30. So when you're pushing that in a square like a dice, when you're pushing that button down, if you try to bag over 30, this particular pop-off will let the breath go, not the quick pop-offs that we use on the other machines. So quick pop-offs, this is the Matrix machine. This one will pop off if you try to squeeze over 30. This one will not. This is what I was talking about. This one will not. It is possible you to hold this down and give a breath over. And then the ModuFlex, this is what I've been calling the DRE. This one does have a quick pop-off too, but you actually have to push that button in. It's got a spring on it. So if you push it in, you can give it a breath and then you let go. And then to shut this pop-off, you actually turn it just like all of our other pop-offs. So there's your pop-offs at OVRS. Some of these machines have been labeled inspiration and expiration in case you had to use the ventilator for it. So as far as the waste anesthetic gases, you know, I wrote an article on those, and basically some of the latest research shows that waste anesthetic gas exposure has been associated with increase in medical errors, drug and alcohol addiction. So we clearly want them out of our room, which is why boxing animals down is not really cool. Masking animals down is not really cool. And to make sure that when you do hook up your anesthetic machine, that you do have your scavenger hooked up properly. Can anybody tell me what's wrong with this anesthetic machine? This is in the museum, okay? I will tell you it has nothing to do about these old black rubber hoses or this cheap rebreathing bag or the fact that there's no soda sorb in here. Can anybody tell me why this machine might belong in the museum? It does have a pop-off on it. Does anything look different to you guys? It looks completely fine. So this is in the museum because what you would do is you would, put your animal under anesthesia, and then the waste anesthetic gases would come out of the little slits in the side of this pop-off. So they would come right back into the room. There was no scavenging on this machine. So that is why this one is in the museum, and that's how you know how big of a nerd I am, because I love pictures of museum pieces from the anesthetic machine. So induction chambers, I think that the one thing around here they're good for is pre-oxygenating. So if you can pre-oxygenate cats, instead of them turning purple after 90 seconds, it will take 3 to 4 minutes for them to turn purple with your induction agents. And I always recommend pre-oxygenation whenever I anticipate a difficult intubation. I always anticipate a difficult intubation whenever I'm anesthetizing a cat, because unless you know the secret password in the handshake, you're not getting in there, right? It's top secret in there. So for the most part, is anyone a member of the Facebook page Veterinary Anesthesia Nerds? Couple of you? Just 2 of you? Okay, I'm going to go throw candy at both of you. So, and if you ask about an induction chamber there, they will actually stone you right through the internet. So, because they're really frowned upon, block the box, that kind of thing. So here I hope we're really not doing that. Actually at OVRS we do have this induction chamber evacuator. It belongs to me and it lives in CT, so if you absolutely found that it absolutely necessary that you had to do this, it's a machine basically that sucks all of the waste anesthetic gases out of the chamber real fast and shoves it into an F-air canister. F-air canisters, for the most part, we're using only these Surgivet models because they hold a lot more waste gas than the older ones. The older ones only hold about 50 grams. These Surgivet ones hold about 100 to 120 grams. I will tell you that they're very fragile, and if you drop them on the floor, they split their sides and go into the garbage, so be very careful with them. And I will also tell you that you have to make sure not to block the holes at the bottom, and that these canisters are designed to operate in an upright manner. They will not work if you put them on their side, so always make sure that they're in their holster and they are upright. So this becomes a real problem when the power goes out a lot here at OVRS. And if you're doing an anesthetic case and your machine is hooked up to the active scavenger plugged into the wall, you can assume then and there that it's not working. And all of the waste anesthetic gases are going to be coming into your room. So as soon as the power goes out, make sure that you grab one of these F-air canisters and make sure that you hook it up onto your scavenger hose. So the Surgivet, the purple Surgivet canisters are able to fit both the 19 and 22 millimeter hose, so it is likely that it will fit. And I do weigh these every week, and I throw them out when they weigh more than 110 grams. I basically weigh them when they're new, and then I put discard add, and I add 110 onto that number to be right in the middle of what they hold. Another really important thing about these active scavenger interfaces is if you're not using both of them, the open port right here has to have a red cap on it. If it doesn't have a red cap on it, that means waste anesthetic gases are coming out through this unused port. And probably the most important thing I want to stress to you guys is maybe you have that 200-pound dog and you have a 5-liter bag on your machine. And if you're going to give that animal a breath and you're going to try to empty that bag, then you actually have to watch this bag on the bottom of these machines to make sure that you're not overburdening the bag, because you have to wait for the scavenger to do its job. So you might have to squeeze a little bit, watch your bag down bottom is going to get big, and then it's going to slowly get small, squeeze a little bit more, wait for that bag to catch up, because if you go gangbusters and like, I'm going to empty this bag, all of it right now, so you watch your bag down here get really full, and you overfill that, and what happens is you see these little holes right here. When this is over full, the gases in this bag, when it's over full, come out of this hole right here. So you've just pushed those waste anesthetic gases back into your room. So be very careful. Make sure that your machine is always hooked up to the active scavenger interface, the unused ports are capped, and that you wait for these active scavengers to catch up when you're emptying your patient's rebreathing bag, that you're not overburdening the blue bags down bottom. I do change them twice a year because they dry rot. And it is conceivable too. One of the things I learned when I was writing this paper on waste anesthetic gases is it is conceivable, whether we're using one machine in the hospital or all 10, that there can be a different burden on the scavenger and on these bags and how full they get. Technically, you are supposed to adjust this knob based on the hospital demand. For the most part, I will say that I think right now, even if we were using all of them, it's unlikely that this bag would get big, but if it was, technically, that is your responsibility to say, this is not doing its job, maybe we need to increase the suction here. But I think it's highly unlikely we use all 10 machines at the same time. But this makes sense to me. So here is that blue one, and again, we have changed this. I think we had this bag here. I think we have now a local anesthetic waste gas collection that is less fussy. We were having terrible problems when we got this machine, but I think right now it's doing a lot better for that blue one in OR1. So no stick in that bag if that's in there. All right, and then leak testing. It's really, really important that you guys know how to do a proper leak test. This is from when I was working for Veterinary and did anesthesia machine repair. Look at this one. This machine is leaking from the inlet and the outlet. So waste gases can come from anywhere. One thing is connected to something else in the machine. And you can either call me in, which I will find the leak. It might take me a couple of minutes. Andrew knows I will find the leak. It's like I become like a detective, like I'm a drug sniffing dog, and I must find the leak. Freon detectors are also a halogenated gas. So if you got close to a leak, they beep, 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 beep. They beep real fast when they come to a leak. But for the most part, all of the machines we have are very, very tight, meaning that they don't really leak at all, which is good. So to do a leak test, I completely disagree with this picture because technically even the bags can have a hole in it. I'll show you guys how to do a leak test with the F circuit, and I do use a bag. Technically the bag could have a hole in it, but you want to pressurize the circuit and then watch for the needle moving. And I can actually even see how big is my leak by turning up the oxygen flow until my needle stays without moving, without dropping down. And then I can look and see, is that a 200 milliliter leak or is that a 1 liter leak? Because if it's a 1 liter leak, you wouldn't want to use that machine. You want to find that leak. But yeah, I will show you guys how to do that at the end here. And this says to pressurize it to 30. I mean, I will never in my right mind give a breath to 60, so I don't really care if the machine leaks at 60. I don't want it to leak at the most commonly utilized pressures, which is going to be under 30. And then make sure that you always open the pop-up when you're done checking for leaks. If you want to cheese off the people that you work with, you will leave that shut, and they'll be very mad at you. But flow leaks under 300 milliliters per minute is considered acceptable, and that would be for some of the dinosaurs that are out there, so that 1939 machine or the one that looks like it belongs in somebody's kitchen. It's got a cabinet and all these pretty columns and all that. But for our machines, we're not seeing anywhere near this size of a leak on all of these machines. They're very good machines. One thing I did want to mention about the SurgiVet machines is that they do collect carbon dioxide and waste gases in order to read this carbon dioxide waveform. And if you look at the side of the SurgiVet, you can see there's a small hole right here. And this is where the waste anesthetic gases and carbon dioxide sample are ejected from the SurgiVet machine. So if you're monitoring carbon dioxide, you do have to make sure that you have your scavenging hose hooked up onto that location on the side of the SurgiVet, and that tubing actually does go into the active scavenger interface. You can either put it at the back of the pop-off, as this picture shows, or you can put it right onto the active scavenger interface before your blue scavenger hose fits in. So some troubleshooting tips. For machine leaks, I would say one of the first places to check is around your rebreathing bag. Holes get right around the neck there. That's my number one place to look. My number two place to look is the soda sorb assembly. If somebody changed it, they didn't, tighten it down and cinch it in there very well. Valve domes can be loose. Make sure your pop-off is closed. Make sure your vaporizer is securely seated both at the inlet and the outlet. Make sure there's not a loose connection. Like when we were checking for leaks, we actually were using one of the F circuits where it had a crack right on the short section of hose that I used to do my leak test, and that's how we found a 1 liter leak. Patient won't go under, again, do a leak test, make sure you've got gas in your machine, make sure you've got, your oxygen is on, you've got proper flows. And then patient wakes up during the procedure, again, check for leaks. Make sure your soda sorb is not old or expired. Make sure you got gas in your machine, and make sure you've got your proper flow rates. I will add one more to that. So there's been twice now that happens to me where the animal is like literally climbing off of the table, and I just smell tons and tons and tons of waste anesthetic gases. Like I feel like the bottle is being opened up and poured on me. And 2 times now I found that the vaporizer cap wasn't on tight. And if you look at it, you can see bubbles coming out of the side of it. So I'm telling you this because you are allowed to learn from other people's mistakes, including my mistake. Now, I don't know twice who filled the vaporizer but didn't tighten the cap down very well, but that will not happen to me a 3rd time without me immediately checking my vaporizer cap. But that is very classic. Trying to leave, and you smell tons and tons and tons of waste anesthetic gases. Okay. Other troubleshooting tips: the bag is overinflated. Make sure your pop-off is open. The pressure on the gauge, 1 to 3 centimeters can be normal, even especially for these ventilators. When we use these ventilators, they're all designed to operate with about 5 centimeters of PEEP. And actually, if they lose that 5 centimeters of PEEP, they won't work properly. There'll be alarms associated with that. Make sure you didn't choose the wrong bag size. The bag does not inflate. Check for leaks. Make sure your active scavenger isn't sucking too hard or too much, because that is conceivable. If it's over adjusted, it's just sucking the gas right out of the circuit. Make sure you've got your right bag size and your oxygen flow. Make sure you're always plugged into your oxygen system. And double check those valves too, those inhalation and exhalation valves. Okay, so before every surgery, double check all of your connections. Ideally, perform a leak test. This is every day. Clean your bag, your circuits. To be honest, these F circuits come right on there, and they say, do not immerse. And if you wash them, they will never, ever dry. So the things that we really have to do disinfection to are things that come into contact with the mucous membranes. For the most part, that would be the endotracheal tube. If you're going to be doing anesthesia on, say, a fungal case or something like that, we do have some bacterial filters that you can use so you don't contaminate the whole entire anesthetic circuit. But I will also tell you it's extremely rare that we have to disinfect the innards of an anesthetic machine. And Harry Latshaw wrote a little article on that one time. The inside of that is very alkaline. I don't think it's very hospitable to microorganisms, so that is why we don't often have to disinfect the inside of the anesthetic machine. And most of the time we're not even doing a lot with these hoses. These bags, I will tell you, we probably should clean them more often. I feel like we use the 5 liter one time, it hangs on the wall for 6 months and gets a hole around the neck. Like, I know we hardly ever use them, but they get holes in them all the time. And then we actually do have our vaporizers checked every year, and we do have them serviced periodically just to have all of the calibrations done, have the wick and all cleaned out there. And some vaporizers, like if we had Sevo here with one of those Abbott Penlon vaporizers, there is actually aluminum components inside of those vaporizers that deteriorate with time, and you have to service them. You can't even get out of that. And then if there's a hole in it around here, we don't save it, just throw it out. It needs to be new. So what is mechanical dead space? If you would have read the 2018 AAFP feline anesthesia guidelines, this picture's right out of there. Mechanical dead space is areas where the gases just go back and forth in the circuit. And technically, if this was that 12-ounce kitten and the endotracheal tube was sticking out this far, it is conceivable that the gases would only go back and forth in the area and that little kitten would never get a breath of air. So that is what dead space, mechanical dead space is. It's areas where you have bidirectional flow, so traffic going past each other one way and another way. And that is why we always want to cut the tubes. You can pre-measure these tubes. You can hold it up to the side of the animal's face before you even knock it out and pre-cut these tubes and get rid of this. Because also if you're monitoring carbon dioxide, your carbon dioxide measurements are not going to be accurate with all of this mechanical dead space here. Because even the carbon dioxide sensing T, we're technically also adding some mechanical dead space into the circuit, but I don't want to have any unnecessary mechanical dead space when I'm anesthetizing, especially these smaller animals. So can you guys understand now where the dead space is? It's just places where gases run into each other. Somebody's coming in, somebody's going out. It's an intersection, it's a crowd. There's a flag on the play. So what's wrong with this? So this actually is a picture that it's an opportunity to win some candy. I walked into the x-ray room one day, and the person that was with me, we recognized that something was wrong. And maybe some people's first thought were, God, somebody was stupid, but you know what? That was not my first thought. My first thought was, who is this person? They need education. They don't understand how this works. And so there's at least 4 things wrong with this, at least 3 things wrong with this machine. You guys want to shout it out for some candy? The tube's not put on correctly, yes. Heads up. Who said the action's left on? That's a hard one. Did you see that too, Dr. Matisse? No. Action's left on. Yeah, I'm a terrible shot. Terrible shot. What else? No bag. Are you a star? No bag. Yeah. So no reservoir bag. And this is where the reservoir bag was supposed to go, right here. The F circuit was hooked on wrong, and the action was left on. So again, if you don't understand how to use this equipment, please let me know, because I don't judge. I just want to teach you guys how to do it correctly. That was my first thought, is who is this person? I want to meet them. I need to train them on how to use this. So do you guys have any questions about the anesthetic equipment part of our journey today? Do you need to run to the potty? Question here. Oh, yes.
Our machine in internal medicine, I noticed on Friday it had the sorb hasn't been changed since September, but it's not purple.
Yeah, so I think you guys are supposed to be using the old sorb. So when you're monitoring carbon dioxide for all of your cases, as long as you're not seeing IN CO2 more than 2 to 5, or your exhaled carbon dioxide numbers are still normal, then technically it's still good. Technically, machine number 5, this one here, the sorb LF, because it's hardly ever used, I've actually left the LF in there for up to a year. Once it gets to a year, I just have an ethical problem, like it's a year old, maybe I should change it. But it's really going to be based on common sense and what is the size of your patient, how much carbon dioxide are they making, so how much burden is there on that carbon dioxide sorb to work. You'll see some of the machines are bigger, like the SodaSorb assembly on the Matrix machines, it can hold more SodaSorb than the EVAD machines. So theoretically, I should be able to use those machines for longer because they hold more volume of SodaSorb. So think about, how long are your procedures, what are the size of your animals, and that is going to ultimately determine how quickly you go through the SodaSorb. It's not just the straight hours thing, because you really have to put common sense into it, like I talked about earlier. So yeah, it could still be good. So does anyone know the carbon dioxide content of room air? And you can just start shouting it out. It's kind of fun for me. Carbon dioxide content of room air?
5%.
5%? Anybody have any other thoughts? Because I know you are a gigantic nerd if you get this right. I know you're a gigantic, gigantic nerd. I will say 5% is high. 0.04%, Katie, is the carbon dioxide content of room air, which means that you never want to be inhaling carbon dioxide. You only want to be exhaling carbon dioxide. So in an anesthetic machine, 2 to 5 is good. All right. Okay, let's talk a little bit about monitoring parameters. I like this cartoon that says, oh, this is Dr. Oog, your anesthesiologist. So what we do today isn't a whole lot off what they used to do back in the day. They actually, in the 1800s, used to get people drunk and then hit them over the head with a hammer to knock them out before they would do their anesthesia. But I like this. The key to success is how you implement Plan B. What does that mean? That means you want to be proactive versus being reactive. And that means you have all your calculations done. You have all your supplies set out. And I find that stuff is a good luck charm versus being reactive is like, oh crap, I'm not ready, call in the crash cart, get all these things ready. And I do want to encourage you guys too, especially, are there any people that have been here teching for under 5 years? Because you guys are what I call my green bananas. 5 to 10 year people? Nobody? No yellow bananas? 10 or more years? So you guys are my yellow bananas with spots. So I don't go as far as to call you black, moldy, shriveled up bananas. But one of the things that I used to do back in the day is I used to think that when I came out of tech school, I was supposed to know it all. And then an animal would have low blood pressure. I couldn't get the number. And I would just start thinking, oh my God, I don't want the doctor to think I'm stupid. What do I do? Should I check it again? I have diarrhea, can I go to lunch? Like all of these horrible things because I really thought that I should know it. I think the most important thing when you're a green banana is say, doctor, the blood pressure is not normal. What do you want me to do? Doctor, the EKG does not look normal. What do you want me to do? And just, move quickly on these animals because before I would spend a whole bunch of time thinking, oh God, I should know this, or finally get the blood pressure that's 20. Right, and at that point, it's like, who cares? The blood pressure's 20. Like, you say, doctor, I cannot get a blood pressure. What do you want me to do? That means the blood pressure is low. You need to act now. You don't need to act, 20 minutes from now. So don't be embarrassed and don't be afraid to just say, doctor, what do you want me to do? Because I used to do that and I don't do that anymore. So you want to be proactive and try to catch problems early before they start sliding down that slippery slope and you're crawling in the crash cart and being reactive. So that means you always have to have a plan B. So a lot of these drug sheets and these drug calculations, we can have all of this ready ahead of time. So here is the plan, everything that truly goes into the plan. You have your data on the patient, your breed, species, age, weight, history, all of that. And then things as an anesthetist, I care about cardiovascular function, pulmonary function, organ function. So we need to make sure the kidney and liver are working okay and they can handle, their cardiovascular and pulmonary function can handle these gas anesthesias. And then we'll come up with our ASA rating after doing additional diagnostics. I know Dr. Reapy wishes that every single animal could have a pre-anesthetic EKG done before we knock these guys out, and that would be ideal. But you want to make sure that you have these animals as stable as we can, and we've done everything as far as the workup goes that we need to before we knock them out. So I just want to talk briefly about different monitoring modalities. There's a lot on this slide right here. If you could just pick one, which one would you pick and why? And we'll look at this when we get to the end here. There's all different monitoring modalities that we have access to here with our SurgiVet. Couple things to say that all inhalants are going to be respiratory depressants, and animals may breathe as little as 50% or more than they would in the normal state. They're all potent vasodilators, which means they're all going to cause low blood pressure at some point. And they're going to cause decreased cardiac output. And then the things that we like them for, we like that they're good central nervous system depressants and good muscle relaxants. So we do like that about them. So when I put these normals up here, but basically this is just why we always do a pre-anesthetic TPR or get a TPR when they come into the building, because if I'm going to ask critical care or ER to monitor the vitals every hour until normal, how in the world are we going to know what's normal unless we've got a baseline for these animals? And so if an animal comes in and his heart rate is 60 and I render that animal unconscious and the heart rate goes into the 50s, I don't automatically worry about that animal unless the blood pressure is going down too, because I figure he's in very good shape and his heart is just very effective with every beat. So even though I'm taking him off baseline, I'm going to go by my blood pressure readings to decide, do I need to do something about this low heart rate? So if you want to get a tattoo, it should say, animals under anesthesia, the minimum systolic should be 90 to 100, 100 for cats, 90 for dogs. And the minimum mean arterial pressure should be 65 to 70 is what your tattoo will say. The good news is we have a lot of these minimum parameters, these minimum acceptable values posted in the operating room so that you have them there handy in case you're not a frequent visitor. And then when those anesthetic machines give you the mean arterial pressure, they're actually doing the diastolic plus 1/3 of the systolic subtracted from the diastolic. And so it does all of these calculations automatically for us. And then when you feel a pulse, you might be able to feel that it's low. Usually you have to have about 40 millimeters of mercury in order to feel a pulse, but you won't be able to say, is it normal or is it high, strictly based on pulse, palpation. And stethoscopes, are around. They give us some relevant information about cardiac output or function, but not really good information. Most of the time, to get really good information on heart function, we're going to have to do an echocardiogram to look at the chamber walls and how thick they are and the valves working and all of that. The esophageal stethoscope can give us a little bit more information, but still nothing concrete. And so you green bananas, make sure that you know a P, a QRS, and a T. Your P is your atria depolarizing, your QRS are your ventricle squishing, and your T is your repolarization wave. So in general, what I've learned over the years in general about cardiology is if there's a problem with your baseline, if the baseline looks funny, it's probably a problem with your atrium. And if there's a problem with your QRS, if your QRS looks funny, it's going to be something going awry with the ventricles functioning. So this is cardiology 101. Okay, so EKG tells us electrical activity of the heart, nothing about what the chambers are doing or what the valves are doing or anything like that. And it really doesn't tell me anything about anesthetic depth. Could this animal have a normal EKG, or I'm sorry, have a normal blood pressure? Could this animal have a normal blood pressure?
Yeah.
Who said yes? Yeah, it could. So if that's the only time that secondary heart block happens, that could absolutely have a normal blood pressure. But if these were coming on like gangbusters, then I might be more concerned about that. But one of the things, you green bananas, historically when students come through, like the blood pressure, the heart rate goes down, you want to turn them down. The heart rate goes up, you want to turn them up, and you're not looking at the blood pressure or any of these other parameters like jaw tone, eye position, mucous membrane color, all of these other things that can help us. So if you learn anything else other than this, is there's a lot of reasons heart can go up and down that have nothing to do with how you're working your anesthesia. So we can do alpha 2s. Dexdomitor can cause the heart rate to go down pretty good. So can blocked cats that can't pee and have a lot of potassium built up. And so can high blood pressure or being really cold. And certainly, yeah, absolutely, it could be the animal's too deep. That could be one of many reasons the heart rate can go down. On the opposite side, there's a lot of reasons the heart rate can go up. Absolutely, positively sure, it could be that the animal is too light. But what if we just gave a dose of atropine? Would I expect the heart rate to go up with that? Absolutely. If their carbon dioxide level's really high, if they're hyperthermic, if they have blood loss, if they're hypovolemic, so they're losing blood, that would make the heart rate go up. So all of these things can go up. And then there's a lot of reasons animals can have abnormal heartbeats. Certainly it could be an animal that just was hit by a car a couple days ago, had a femur fracture, we're fixing it now, the heart is still a little bit bruised. It could be heart disease or pain, or some of the drugs we used to use back in the day would cause some arrhythmias, but for the most part, I think that you should be able to recognize these heart blocks. The secondary heart block is very common under anesthesia, and what you'll notice is you have your P, and then your QRS comes pretty close to your P. You start to get a bigger gap between your P and your QRS, and then all of a sudden you lose your QRS altogether. So that's called the Mobitz type 1. The third degree AV block, I hope that you never see under anesthesia. Juliana's dog had that. This means the atria are doing whatever they want, whenever they want. The ventricles are doing whatever they want, whenever they want. There's no communication or rhyme or reason between these beats at all. And then you can also see VPCs under anesthesia. Now, these are VPCs and these are VPCs, but if this animal was on my table, this one would concern me more because those VPCs look completely different from each other, which means that multiple parts of the heart are irritated versus these VPCs are likely all coming from just one irritated part of the heart. So does that make sense? If you see a lot of wackadoodleness, you want to phone a friend. An EKG is not perfect, if you don't have good contact with your leads, or sometimes the complexes are too big and it's double counting, or if the animal is shivering or moving or things of that nature, then it can be problematic for me. I will tell you that if I have lead 2 on and it's not giving me a good signal, I just change the channel. I don't care which one of the leads you look at, as long as all of your players are there. You can see your P, your QRS, and your T, and that you can read the complex as well. So try lead 1, try lead 3, try changing the amplitude. I'll try all of these things to get a good-looking EKG. And then what about, can we use EKG for monitoring anesthetic depth? I always ask the students, what can be the first thing that will let you know that your animal is trying to die on you? And they all usually start with EKG, and I say, ooh, well, you have never euthanized an animal on the table before, have you? Because if you did, you'd know that we kind of take bets on how long it's going to take for the EKG to completely flatline, and that you can have electrical mechanical dissociation or pulseless electrical activity. So near normal looking EKG on a clinically dead patient, not associated with pulses. So EKG does tell me about arrhythmias in the peri-anesthetic period, but not a whole lot more than that. So let's look at pulse oximeters. Pulse oximeters work on infrared light transmitted through the blood. They give us a little bit of information about hemoglobin saturation and the pulse rate. And you have to have really good cardiovascular function for these to work. So they don't work well, like if you try to use them on your dexdomitor cases or shocky cases or hypovolemic cases, they don't have a good pulse to find, and they don't always work really well. But here's the big picture. Every red blood cell has several hundred hemoglobin molecules which transport oxygen. And every hemoglobin molecule can carry 4 oxygen molecules. So I think of these little hemoglobin cars with 4 passengers, 4 oxygen passengers riding on these red blood cell rafts going down the IV highway. That's how I think of these traveling throughout our body. And then your oxygen gets delivered to your tissues, and your cars run out of oxygen, and you have to go back to the lungs to pick up some more oxygen. So there is a little bit of alphabet soup. I want to make sure that you understand. When you see the P little a O2, that's just the amount of oxygen dissolved in your plasma. When you see the SaO2, that means we're going to take the actual red blood cell and find out how much oxygen is on that red blood cell. And then the SpO2, this is a machine-interpreted result for SaO2. And the big problem is that the pulse ox cannot tell me more than 100%. 100% is about as good as it can say. I wish pulse oxes could tell me 500% or 600%, because that could be very valuable information when we're talking about pulse oximeters. So here's the big picture. So here you have a little lung alveoli. We have room air going on. We have a normal amount of hemoglobin, so the animal is not anemic. And here we have this big A means the lung alveoli, so that oxygen gets drawn into the lung alveoli, rapidly gets dissolved in the plasma, and then this oxygen is in the plasma ready to jump onto these red blood cells when there's a vacancy on the arterial side. So these red blood cells are about 97% saturated, which means for every 100 binding sites there's about 3 vacancies, right? 97, 99, 100. If there was all the vacancies were taken, this would say 100%. And the amount of oxygen on this side is 95 millimeters of mercury, breathing room air. On the venous side now, these red blood cells look darker because they're just about out of oxygen. There's not enough or as much oxygen dissolved in the plasma that's ready to jump onto these red blood cell vacancies. And they're about 75% saturated now, so the amount of oxygen over here is about 40, okay? So the problem is that our body cannot use the oxygen dissolved in our plasma. Only about 1 to 2% is dissolved in the plasma. The other 97 to 98% has to be bound to a red cell. So we really cannot use the oxygen that is just circulating in our plasma. We have to have a red blood cell to carry that oxygen to our tissues. Now, if I had this animal breathing 100% oxygen, this number over here would suddenly be 90 or 500 millimeters of mercury or more, 600 maybe. I would have so many black O's typed here that this whole section here would be black. So let's keep that in mind when we put these animals on 100% oxygen. We have hugely ramped up how much oxygen is dissolved in their plasma. So said another way, the amount of oxygen dissolved in your plasma, if it's over 80 in your breathing room air, that means the amount of oxygen on that red blood cell is 95, and that would be normal. But when the amount of oxygen dissolved in your plasma goes under 60, 90% would usually be good, but 90 not when you're on a red blood cell. So the difference between 95 and 90 is the difference between normal and hypoxemia. And the amount of oxygen for our pulse oximeter should always be 100%. So, and that's because of how much oxygen we have dissolved in the plasma. Is everybody with me so far? Again, it's not rocket science, but yeah, we totally need to have these red blood cells to carry the majority of our oxygen. So here's why some people hate pulse oximeters, because again, if I have an animal under anesthesia, the amount of oxygen could be 500 millimeters of mercury or more, but that pulse ox is only going to tell me 100%. And by the time the pulse ox drops down to 90%, the amount of oxygen, dissolved in the plasma is actually at a critical mass, or the animal's hypoxemic. So That is why truly the correct answer for what is the right answer for a pulse oximeter to be under anesthesia should be 100%. And the only reason we say it's 90, 98, 97, 96, anything less than that is because these darn clips crush these capillary beds, and it is the margin of error that we allow this equipment to have. So does that make sense, everybody? If you move your clip, you're going to get a new capillary bed, and you're going to get better readings on your pulse ox. And pulse ox is not perfect. If the animal's moving or you don't have good probe contact, you're going to have problems. You can actually shine your xenon arc surgery lamp right on that probe and get it to say 100% with a heart rate of 180 to 225 without being hooked to a patient. And then they're not always going to work well for us if we have, shocky patients or animals that we just use dextometer on, or if they're hypovolemic or really, really cold or anything like that, we're not going to get a good reading on them. And you actually can have an animal come in with carbon monoxide poisoning and put the pulse oximeter on them, and it will read 100%, but it's fooling the pulse oximeter because all those binding sites are actually filled with carbon monoxide instead of oxygen. So that can mess it up, as can dyes, yellow animals with a lot of pigmentation. All of those things can make your pulse oximeter not really work very well. And although it tells me a lot about oxygen saturation, it really doesn't tell me about anesthetic depth or how am I driving my anesthetic case. So this is truly the big picture on what is involved with blood pressure. But I am not going to give you this information in depth at 7:30 in the morning. But what I want you to understand is that there's a lot more that goes into it, and I'm going to try to simplify it for you. So the stroke volume, how much blood is squished out every time my heart beats one time, how much blood comes out, combined with how fast or how slow is my heart going. That's going to be my cardiac output. But it's also huge for me to think about what's going on with my blood vessels. And I usually have a plastic water bottle that's halfway full here. And I squeeze the sides of the water bottle, and you can watch what would happen to the fluid level in this water bottle if I was squeezing the sides and it was about half full. What would happen to the water level in there if I squished it? It would go up, it would go up. And that's what vasoconstriction does to the blood vessels in your body. And then if I took the same water bottle and I could make the sides expand on this and it could go even bigger than this, what would happen to that same water level? It would drop down. And so remember, whenever we give animals inhalant gases that are potent vasodilators, maybe combined with acepromazine, which is another potent vasodilator, I am suddenly making all of the blood vessels in the body bigger, which means that the fluid level is going to drop, which is why we put animals on IV fluids to make up for the fact that we're going to change the size of their blood vessels. And I had one student tell me that the reason we put them on fluids was because the animal was dehydrated. I mean, are these animals dehydrated? No, because we do blood work on them. They come in. It's just like you sitting in your chair right now. If I put you under anesthesia right now, I don't think most of you are dehydrated. And that is why we care about blood pressure under anesthesia. If you look at this picture, your heart gets only about 5% of the cardiac output, and this is you sitting in your chair, not running around like a marathon, like a crazy person, like a regular day in critical care. Your brain is getting about 14% of your cardiac output, which is the same as the rest of your body is getting. But your liver and kidneys together, these two organs take up almost 50% of the cardiac output. And the kidneys are uniquely sensitive to hypotension, and they actually require a lot of oxygenation as well. So we actually had a case here years ago, an orange cat that came in, had some wounds on it, and it had perfectly normal blood work before it went under anesthesia. It was under anesthesia on the dirty table for 45 minutes, no monitoring done at all, and that animal woke up with acute kidney failure. And that was our fault, because I do tease my yellow bananas with spots that if you listen very carefully, like an animal with borderline blood pressure, it stresses me out, because if you listen very carefully, you can hear kidneys saying, help me, help me. Because, I mean, think about this. Some of my VTS anesthesia colleagues, we talk about this. We talk about what if an animal comes in, has low blood pressure, whether it's not identified, treated, or ignored, and 50% of the kidneys die that day, but the animal will wake up, go home, do fine for a while, and the same animal comes in. The second thing happens again. It's put under anesthesia. Another 25% of the kidneys take a hit. Now we have 75% of the kidneys damaged. Now that is going to show up on blood work. And now could it be that some of these older animals that have kidney disease later in life, could it have been partially our fault from these subclinical insults to the kidneys that killed a certain amount of those nephrons that we never could detect until they get to critical mass and they say, I give up and I'm done. So think about that. If you can, and so whenever I anesthetize an animal, I think about that I have a set of kidneys that I need to keep perfused. And it makes me nervous when I have these borderline blood pressure numbers. And these are what I call cases that are walking the line. And what does that mean? Remember, the systolic we said should be 90 to 100 or greater. So these are cases where I do a blood pressure, it's 89, 92, 83, 96. Like my butt cheeks are clenched because I am thinking, oh my God, these kidneys are getting ready to take a hit. And so I don't like to walk the line, because at any point it could go south, right? You could be doing reactive care. You could be calling in the crash cart. But I want to be proactive, and so I do what I can to make those numbers go up. And the number one goal of an anesthetist is always to use the lowest vaporizer setting you can. That's my goal as an anesthetist. And this is why we use morphine family drugs as pre-meds, and why we use local anesthetics and numb them from the waist down, and all of these fun things, so that I can get away with the lowest vaporizer setting I can, so I can keep my kidney customers happy. So all patients will experience some degree of hypotension under anesthesia. And the American College of Veterinary Anesthesia and Analgesia recommend blood pressure monitoring as a minimum standard of care for managing moderate to severely ill patients. And especially these ASA ratings, the American Society of Anesthesiologists ratings, they say that animals that are 3 or higher, so these sicker animals, we can anticipate these are your tough customers. These are the ones that are more likely to give you trouble under anesthesia. And so every day, animals do try to get low blood pressure on me every single day. So definitely don't let more than 10 minutes lapse before documenting a low blood pressure measures on the anesthetic record and what you did to fix it. Sometimes I'll say, await surgical stimulation, notify doctor. So I know that the surgery hasn't started yet, I just moved in there. I will, mark down, I am turning down my isoflurane. I'll mark down that I gave a crystalloid bolus or what have you. Most of the time, if you have low blood pressure and a low heart rate, you kick the heart rate up and the blood pressure is going to get better most of the time. So we have these oscillometric devices here that detect changes in the cuff pressure caused by the pulse wave. They give us the systolic, the diastolic, the mean. They will tell us every 1 minute, every 3 minute, every 5 minute what these numbers are. And so you must measure these blood pressure cuffs correctly, especially in critical care. If you guys are monitoring blood pressure throughout the day, you need to write down what cuff you use, what number you used, what leg you used, and make sure that it's at the level of the heart. So if this is a blood pressure cuff that I'm going to put on this paw, and the tubes are coming out here, you want to take the distance from here to here, and the distance from here to here should go, the cat rule book says 30% around, the dog rule book says 40% around. So if I had to guess the distance from here to here, what percentage around this paw do you think this goes? Would you say it goes around, I don't know, what do you guys think? 35%. So if you're torn between two sizes, you can choose up, but this would be the correct blood pressure cuff size to use on this limb. And you are allowed to tape it, technically not all the way around, because sometimes these cuffs need to be new, but this is just how you would put that on the paw to measure that. So if the reading, if the blood pressure cuff is too small, the reading will be falsely high. If it's too wide, the reading will be falsely low. If it's too loose, the reading will be falsely high. If it's over a joint, you're not going to compress your artery as much, and if there's a hole, it's not going to measure accurately. So we have this a poster similar to this hanging in the operating room so that we know how important it is to have the correct blood pressure cuff size. And here we do have the PET maps are really popular. They have very specific cuff marks on those. So ideally, this dashed mark right here, the index, ideally should fit within this optimum zone and absolutely cannot go outside of these dark lines. So if this mark was going outside of these lines, you would 100% need to choose another cuff. But I like the PET map because there's like 15 different cuff sizes versus the SurgiVet, which only has 3. And I just sat here and told you how totally important it is to use a correct blood pressure cuff size to do these measurements. So it's my favorite time of day, a tale of 2 patients. So here we have Roxy the Doxy and Noodle the Poodle. Roxy the Doxy is having a disc decompression. We just did a blood pressure on her. We got 85/79 with a mean of 81. And Noodle the Poodle, we just did a blood pressure on her. We got 105/69 with a mean of 81. So who thinks Roxy the Doxy is doing better? Raise your hand. Anybody think Noodle the Poodle is doing better? Raise your hand. Does anybody think that this is a trick question? Raise your hand. Does anybody have no idea whatsoever? Because not everyone raised their hand. Okay. So if we could touch these animals and look at these animals, and let's look at Roxy the Doxy. You see how close all of these blood pressure numbers are? There's not even a 10-digit spread between all of these numbers. And if we could touch that animal, we would find that her feet were cold, her gums were pale, and her pulses didn't feel very good. And if we cut open her chest and watched her heart beating, her heart would be neither relaxing nor contracting with much vigor. And so this is called narrow margins. And you know, the reason I tell this story is because back in the day, remember I just told you, focus on 2 numbers, focus on the systolic and the mean. But these oscillometric devices, they give us all of the numbers, and so now I don't just zero in on 2 numbers anymore, because look at how far apart Noodle the Poodle was. I have 1/5/69 with a mean of 81. I touch that animal. The feet are warm, the gums are pink, and the pulse feels great. And if I cut her chest open and look at what her heart is doing, her heart is beating really, really effectively. I've got really good cardiac output. And so that is why, if you can, try to look at all of the numbers the monitor is giving you. And don't do like I did for years and just zero in on 2 of them. Because you have to put the big picture together in your head to think about, why is this animal doing this for me? So bummer things about blood pressure, they all underestimate actual blood pressure by anywhere from 10 to 30%. And they're going to work best when the mean is, you know, in a normal range, 60 to 90. If you have the little bitty guys, less than 5 kilos, they can be tricky. If you got little short legs with a lot of skin like the dachshunds, it can be tricky. If they're moving, it can be tricky. If they're really cold or vasoconstricted, that's not good. And then what if the limbs have edema and they're all stocked up? You know, so all of these can make it tricky to get these really important numbers. But I always like to do a pre-anesthetic blood pressure so that I know where my animal's starting out, and I also check my cuff size and my signal strength. And then I know how far off of that baseline I'm taking them once I render them unconscious. And some of us do have the Doppler and use the Doppler for blood pressure. And here is my slap-it-on Doppler technique that I swear by. So this is the back foot of a cat. What I like to do is take my crystal right here. This is my crystal, and I put it over the artery, and then I put one piece of tape around there. Then I take the excess cord, I wrap it in between the two middle toes and put another piece of tape right here. Now you can do this on bigger dogs too, but you have to understand that it's more medial. So you'd be wrapping your cord in between the first and second toe versus the two middle toes. But I still do two pieces of tape on top of each other. And then and only then do I turn the Doppler on. And 9 times out of 10, you'll just hear push, push, push. And then I put my cuff on above there, and I like to leave the Doppler on because sometimes people will actually put their cuff on so tight that they dampen their signal, and then you can't hear anything. So I like to put it on so that I can make sure I'm not putting my cuff on too tight. And then you go ahead and get your reading. For cats, for the love of all things holy, cats, they already had a bad day. They didn't get breakfast. They were shoved in a box. They went on a car ride. They pooped and peed themselves. And now if you're expecting to get an accurate blood pressure out of them with I can't make my microphone do this, but with all of that noise, that is going to scare the crap out of them. So these blood pressures should be done in quiet areas, preferably with a pet owner. And this cuff, also remember, whether you're using Doppler or oscillometric, these cuffs have to be at the level of the heart. So for every inch you're above or below the level of the heart, your reading is going to be off by 2 millimeters of mercury. And if you don't believe me, go ahead and try it yourself. Put your blood pressure cuff on your wrist, get one reading up in the air, one reading down by your waist, and a third reading up at the level of the heart. So even oscillometric, Doppler, these cuffs all must be at the level of the heart. Very important. So that is how you do it. And then as far as what leg to do, I prefer that there be a lot of good, not a lot of extra squishy tissue behind the cuff. So the radius ulna is my first choice. The tail is my second choice. The back foot is my third choice. If I have to do the back foot, I do below the hock. You don't want to be wrapping up a lot of squishy tendons and tissues around your cuff. That will make it harder to get an accurate reading also. So in cats, they say you get the mean. You have to add this 14 millimeter correction factor to get the actual systolic reading in the cat. And in the dog, you get the systolic only. So can I tell if the animal has narrow margins with a Doppler? I really couldn't know because I only am getting one number. I'm not getting 3 numbers to compare. So I always like to run a Doppler on my cats and cat-sized dogs because whenever I'm not writing down something on my anesthetic record, I have my finger on a pulse because I am still the one that's letting the doctor know, am I buying what these machines are selling, and do we have a problem? And so with my cats and cat-sized dogs, where maybe it's tricky to feel a pulse, I will listen to pulse quality. And you can hear psh, psh, psh. So I could listen to if the pulse quality is dropping versus having my hand on a pulse. And Doppler's not perfect either. We've all fussed with these things. We just talked about it's super important to do the right cuff size. If they're panting or moving, it's going to be tricky. We only get one number in there. If the probe is not exactly on the right spot or you don't get good contact with that tissue and that artery, or you have low batteries or interference, all of those are going to impact the quality of the readings. Let's talk briefly about carbon dioxide. Carbon dioxide is transferred in the body in 3 different forms. Most of it's as a bicarbonate ion and another 20 to 30% bound to proteins. But this little tiny amount dissolved in the plasma, this 5 to 10%, this is what we measure with our end-tidal carbon dioxide readings. And you've seen this picture before, but I love carbon dioxide physiology because it follows the KISS principle, which is keep it simple, silly. So it doesn't matter whatever bed you're in, whether you're in the lung alveoli, the number's 40, and capillaries, number 40. Mixed venous, this is where your arteries and veins are running into each other at an intersection. It's only about 6 millimeters different, 6 millimeters of mercury different in these traffic jam areas. And we need three things to make carbon dioxide. We need to have cellular metabolism, so we have to have our cells taking the oxygen, giving off their carbon dioxide waste products. We have to have blood flow, so our heart has to be pumping effectively. And we have to have our lungs doing proper gas exchange, so we need to have alveolar ventilation. Our tattoo says normal is 35 to 45. We know that animals under anesthesia aren't going to breathe as well, but in critical care, we can make sure that we're doing a good job with our CPR. If we can get animals to make at least 20 millimeters of mercury with your CPR efforts of carbon dioxide, then we know we're causing all three of those things that we just talked about. And it's fun to measure it for anesthesia as well. So again, these tubes have to be cut. You have to have them end right at the nose. And then when you look at your capnogram, we know it goes down to 0, since we know the carbon dioxide content of room air is very, very low. But that is your actual end tidal carbon dioxide number right there. And then we talked about earlier, you want to get rid of that mechanical dead space, so cutting the tubes is going to be very important. So here's a capnogram. You got to put your thinking cat on. So do you guys think this waveform is normal or abnormal? Abnormal? What don't you like about it? It does not go down to baseline. Who was saying that very quietly? You were? All right. I'm throwing a star at you. Very good. I'm a terrible throw. Okay, so yeah, so this could be possibly, it's also going high, so this animal is inhaling carbon dioxide and has high carbon dioxide. They're exhaling as well. So I might look for a problem with this with my flutter valve. It might get stuck up. Sometimes you got to smack it, or the soda sorb could be old. Those are the first two things I'd look at for those. All right. So we can have to troubleshoot carbon dioxide. We talked about the valves in the circuit. If they get stuck up, sometimes you have to go ahead and whack those. We talked about what can happen with an inadequate seal. The side stream technology we use, we do have to troubleshoot some of those lines and chambers. They can sometimes get kinked over or get plugged. And it will let me know about respiratory rate. Maybe if my respiratory rate went down to 4 or 3 or 2, I might worry about depth. But other than that, it doesn't tell me a whole lot about anesthetic depth. It will tell me if my animal is getting ready to crash on me, because a sudden decrease in carbon dioxide can be an early and reliable indicator of an impending cardiac arrest. And so if I don't see carbon dioxide when I expect with the next breath, I immediately check my patient. The good news is that animals do not try to die on me every day, but they do have low blood pressure on me every day. Temperature, I'm not going to spend a lot of time on temperature, basically to just put common sense into it. So if I have the belly open and I have an esophageal temperature probe in and I have a rectal temperature probe in, if the belly and the abdominal contents are being exposed to ambient room temperature, it would make sense to me that my rectal temperature might not be the most accurate because it is close to tissues that are exposed to ambient room temperature. But unfortunately, the critical care staff, they're not going to monitor the esophageal temperature every hour until normal. So we still write these numbers down. And these ear thermometers can be very accurate if they're used appropriately. A lot of things happen for animals to drop their temperature. We shave off their hair and the operating room is cold, and we give them vasodilating drugs like acepromazine and gas drugs, and then the surgeries are long, and maybe the animal is really old or really young. So nothing good happens from being really, really cold. In fact, animals that are really, really cold, you can give all the atropine you want, it won't work. So you must warm these animals up. And what I like to do is, if I was naked and going to take a nap, I would not choose a cold stainless steel table. This is how you'd want to have everything covered up. So prevention is key. Work really hard to keep these animals warm in surgery, because I also remember that the colder these animals get, the less their inhalant needs are. So the colder they get, I automatically start decreasing my vaporizer setting, understanding that cold itself is an anesthetic. So the colder they get, we start decreasing the temp. And then you ideally want to use like our bear huggers and hot dog warmers and that kind of thing, because you technically need to cover at least 60% of the body's surface area in order to do effective rewarming. 60% or more has to be covered with your rewarming, with your warming device. So if you're putting a hot water bottle in their armpit, you know, that's not really covering 60% of the body surface. The other thing I don't like about hot water bottles is as soon as they cool off and get to the temperature of that animal, they're actually taking heat away from that animal, just like the table or the cage, the stainless steel cage that they're in. So food for thought, several studies indicate that between 60 to 93% of anesthetic complications can be detected by an electronic monitor before a trained anesthetist, and that alarms are ignored or silenced as being annoying. So my take-home point here is for you guys to understand that these devices, all of these different monitoring parameters, they're there to help us do a better job and to alert us to problems before they get real bad. So, you know, use them accordingly. So, did you guys have any thought about, as we go through this presentation, board-certified anesthesiologists were asked to choose from this list of equipment what would be the most valuable tool for monitoring animals under anesthesia. Did you guys were able to guess what the anesthesiologist chose based on what I went through today? Blood pressure, yes. Because animals, again, they don't try to die on me. Each one of those monitoring modalities, they're like a boyfriend to me. You know, I keep them each around for a different reason. Like the pulse ox, he tells me things about, you know, oxygen saturation. Carbon dioxide lets me know if my animal's going to drop dead. But again, that does not happen every day. But blood pressure, every single day, you will hear kidneys screaming for help. And every single day, you will be troubleshooting animals that are teetering on the edge of low blood pressure. So yes, they picked blood pressure. And I would also say that you know, could potentially be the correct answer there, because you are still the one that is letting the doctor know if there's a problem and troubleshooting this equipment and putting all this information in your head. So before we run off, I did want to take a couple minutes to talk about the monitoring guidelines at Oakland Vet Referral Services. Technically, you know, when I first started here, I tried to introduce the dots and squares and triangles type graph that we used at the university, but people started to get a little twitchy and their eyes started to roll in the back of their head. The problem is it's very, very difficult for someone to look at a record like this and see, can you see a downward trend? You can't, because your brain is trying to look at all of these numbers and kind of put them together. But this is what we have, and these are legal documents. The reason we started implementing these was because of a veterinarian brought her dog here, and it went under anesthesia, and shortly after it went under anesthesia, it arrested. And that veterinarian wanted to see the numbers and the records, and there were none. And so if you don't keep anesthetic records, you can't prove that you did a bad job, but you can't show that you did a good job either. And for me, as an anesthetist, every single time I anesthetize an animal, I want to do a better job. So I look at these old records and I see, how did that animal do the last time I had it under? What size endotracheal tube did I use? And then I try to do better. If the animal had borderline blood pressure, maybe we don't use acepromazine the next time around. I actually had written, even on a problem list, I put in an anesthetic record, could only get a 9.5 tube into this 70-pound lab. And so I overhear a big ruckus in the x-ray room, get me smaller tubes, get me smaller tubes. So they end up putting like a 9.5 in the dog, and I mean, if they would have looked at my prior anesthetic record or the problem list, I wrote there I could only get a 9.5 endotracheal tube in that animal. So you do have to look at the prior records. They can be simple or complex. We're also not technically supposed to write spontaneous respirations anymore. These these spaces should have a number in them. Someone will have to count that. If you do the carbon dioxide monitoring, the machine will count it for you. Otherwise, make some time when you're inducing these animals to do that as well. And then I also write helpful notes at the bottom. Extubate, smooth recovery, gave hydro, total IV fluids in surgery, all of those things I put at the bottom there. So the last thing I wanted to cover was the OVRS monitoring requirements. These are posted in a lot of different locations around the hospital, but basically the induction guidelines for young healthy patients, you're going to want to get a baseline heart rate, pulse oximetry reading, and a respiratory rate. Animals that are high risk or sicker or elderly, you'll want to also add blood pressure onto that. You can either do a PET map or a Surgivet, and you can also use a Doppler. The Doppler is only going to record the systolic in dogs and the mean arterial pressure in cats. And ideally, you want to get these readings about once every 5 minutes, not more than 10 minutes should elapse between readings. I also like to stress that I prefer that everyone does a pre-anesthetic blood pressure, so that way you can get a baseline before you anesthetize them, and you can make sure that you have a good blood pressure cuff size and a good signal strength before you anesthetize your animal. For the operating room, the monitoring continues, ideally with the addition of carbon dioxide and temperature, and you should do those readings approximately once every 5 minutes. In the x-ray room, if your procedure is going to be more than 15 minutes, you should also perform blood pressure monitoring on these animals, specifically if they are not able to control their airway. So if they're that sedated where they can't swallow, you would 100% want to do all of the monitoring parameters that the animal will allow, and especially if the procedure is going to be a longer procedure. But if the animal is sitting up or moving a little bit and able to swallow, then you don't have to get as aggressive with your monitoring guidelines. For animals that are sedated for more than 10 minutes with, say, drugs like dextomator or ACE hydro, again, we're going to want to monitor these animals very diligently, especially if the procedure is going to last more than 15 minutes. Okay, so I think that was all I had for you guys. I like this saying, all of the monitoring equipment in the world cannot replace an educated and attentive anesthetist. So again, you guys are still the ones that are letting the doctor know, hey, there's a flag on the play, what do you want me to do? Or in troubleshooting this equipment, or everything's fine, keep plugging along and we'll get through this together as a team. So this article was published, Anesthetic Monitors, Understanding Their Use and Limitations, was in the NAVTA journal. I did have some handouts for you guys, but I think you might still have them from last time, right, Kit? No? Okay, I have some for you if you want some notes, or if you want to copy this article, that's cool too. So do you guys have any questions before you run out for home or back to work? Yes?
Just me again. So we, for ultrasounds, oftentimes use like really low dose dextomator, and they're still like the highest she ever goes is usually 3 micrograms per kg.
Mm-hmm.
And they're still usually moving, and they're still usually like aware, but do you still want us to get out all of the monitoring equipment for those? Like, I'll put a pulse ox on them for the most part, but do you still want us to get blood pressure and EKG and...
So it would depend on the case. I imagine you ultrasound a lot of older, sick animals, then I would definitely consider the blood pressure and the pulse ox and the EKG, whatever you can do that I mean, clearly you might not be able to monitor carbon dioxide. Now, technically, with a face mask and a carbon dioxide sensor with oxygen, you are supposed to be able to measure carbon dioxide even with a face mask with oxygen supplementation, but you should, I'd rather you play it on the safe side. If you have sick, compromised animals, you know, and they'll tolerate putting a blood pressure on and an EKG, you know, and a pulse ox, I would say you should do it. The thing is, I can find reasons to, I can find reasons that could be problematic to under monitor an animal. I cannot sit here and think of a good reason or a contraindication to over monitoring an animal or being on the cautious side, because people spend thousands of dollars to come here. We are supposed to be a facility that is setting the standards for the community and practicing high-level anesthesia care. And so for me, you know, even with Lucy, when we're doing some of these sedation cases for young, healthy animals with, you know, pen hip evaluations or whatever, we still try to do at least blood pressure and a pulse ox. But again, I'm not anesthetizing 14-year-old animals with liver disease or whatever, in which case I don't see a downside to adding EKGs either. And this just makes sense to me too. I mean, you know, we're just trying to catch things early. And if that equipment's gonna help you catch things early, then I think it's worthwhile to say all in. So what we're gonna do first is follow the flow of gas through this EVAD machine. The first thing you're gonna do is turn on your oxygen supply, which your wrench is on the back of the machine here. And so right now, if you look at this, the needle is down at the post, which means this tank is either empty or it's not turned on. So we try to store these in the off position, so we'll go ahead and open that oxygen supply there. Just a couple of turns there. And you can see there actually is quite a bit of oxygen left in here, so we don't have to change this tank right now. Once the oxygen leaves the tank, it goes through this green line. It actually is attached to the flow meter on the other side. This location is where it goes into the flow meter, and this part also ties in your oxygen flush valve on the other side. And when I flip that machine around, this is the tube that's coming out of the back of the flow meter. So we'll go ahead and flip that machine around. And so we know the first stop is going to be the flow meter. And the flow meter, the tubing coming out of the top of the flow meter is right here. And we know that the second stop is going to be the vaporizer. And if you look very carefully, you can see arrows stamped into the vaporizer. So I know the gas goes through the vaporizer in this direction. So then it's going to come out of the outlet and come through this tube right here. And then the gas comes down through this tube. It travels in this orientation, goes through this one-way directional valve. You can see the arrow pointing there. That's the inspiratory side. The gas goes through the inner teal tube. The animal is inhaling. Then once they exhale, the gas goes through the outer tubing there. And then it's going to come through this tube. And this is the expiratory side. There's an arrow pointed there. And it goes through this one-way directional valve. And then the gas goes down through here. You can see your animal breathing. And then the gas continues to travel down here, down through this tube, goes across here, and then starts to percolate from the bottom through the top of the soda sorb assembly and rejoins the cold, fresh incoming gas right at this location. The rest of the gas goes out of our scavenger through the pop-off here and our scavenger hose into the active scavenger interface. You always want to make sure that your open ports are covered with this red cap, as open ports will allow waste anesthetic gases to come into your room. And you always want to make sure when you're emptying your rebreathing bag that you watch this WAG bag as well to make sure that it does not get overly distended, since once this bag gets completely full, the waste anesthetic gases will come out of the holes on top of this interface and come right back into the room. So on the really big dogs with the big 4 and 5 liter bags, You absolutely can over-distend this bag, so just make sure you empty the bags on those bigger animals slowly so that this has a chance to catch up before you keep emptying your rebreathing bag, or else you'll get the waste anesthetic gases right back in your room. And ideally, you always want to use your active scavenger interface whenever possible, since these F-air canisters are only good for about 100 to 120 grams, but if you need to use it, if you don't have access to your ceiling scavenger, you would go ahead and make sure that you plug your scavenging hose into your F-air canister. The F-air canisters do always have to remain upright, in an upright position, so they should never be placed on their side or anything like that. The next thing we're going to do is go ahead and check this anesthetic machine for leaks. Everybody should know how to do that. And what I like to do is just get one of these F circuits and take the little dead end off of that to make a dead end on my anesthetic machine. And so now we have our bag in place, and we've made a dead end right here with that. So what you're going to do is shut your pop off, and then you're going to pressurize the circuit. And with this safety feature in place, we really shouldn't be able to pressurize this circuit for more than about 20 centimeters of water. And here you have that safety feature activated, where even if I push the action flush valve, I'm not able to get that to go more than 20 centimeters of water. So these always belong on the expiratory side of the machine, and these should never be removed. These will work even with a ventilator in use. You also want to check the machine without this safety feature, so we'll make sure that that safety feature is working correctly. But we'll go ahead and pull that off, and then we'll go ahead and recreate our dead end. And again, I'm going to push the action flush to pressurize the circuit. And we're going to just check that right to about 30 centimeters of water, since I would never, in my right mind, ever bag an animal to over 30 centimeters of water. So I don't really care if it's going to leak at pressures over 30 centimeters of water. This particular machine, all of our machines are newer machines, and they're very tight machines. They don't leak at all. So now that I've demonstrated how to check your anesthetic machine for leaks, I would like to go ahead and demonstrate how to hook up the non-rebreather. At OVRS, we have these safe size that also have a little pressure manometer, so you'll know how much pressure you're putting on the animal's lungs. And these are for animals under 7 kilograms or definitely under 3 kilograms. I'm going to highly recommend everybody read the 2018 AAFP Feline Anesthesia Guidelines. I do have access to that document, but it's really nice document for safely anesthetizing cats, and it's got very good standards for that. So if we're going to hook up this non-rebreather for cats or cat-sized animals in under 7 kilograms, we're going to go ahead and want to access the machine right where we know oxygen and inhalant are coming from. So we're going to go ahead and remove that tube at this location. And then we'll go ahead and hook it up to this little Christmas tree right here. And you always want to make sure to hook up your scavenger into the active scavenger interface. So now for this non-rebreather, what we have is we have your oxygen and your inhalant gas coming down this tube here, right to where the animal would inhale with the endotracheal tube, then they'd exhale. The gas comes down this tube here. In order to give an animal a breath on the safe side, you do have to depress this button, and then you can go ahead and squeeze your bag. Once you let the button go, it will release the breath, so it is impossible to damage an animal's lungs with this one. And when you're depressing the button, you can actually look at this little pressure valve to make sure that you are not putting too much pressure on your patient's lungs. Okay, the next thing I would like to demonstrate is how to hook up the induction chamber at OVRS. I will tell you that we should avoid using induction chambers if at all possible. Induction chambers are associated with a lot of waste anesthetic gas exposure to staff members, and it is also associated with stress. So you can use induction chambers for pre-oxygenation. If you can pre-oxygenate an animal for at least 5 minutes instead of them turning purple after propofol induction after 90 seconds, it can take up to 3 minutes. So pre-oxygenation is always an excellent idea whenever you anticipate a difficult intubation, and I always anticipate a difficult intubation whenever I am anesthetizing a cat, since you're not going to get your tube in unless you know the secret password and the handshake. So here is the stuff we need to hook up the induction chamber. And what you're going to do is go ahead and remove the oxygen supply from this location on the EVAD machine. Then you're going to go ahead and hook your Christmas tree into that tube. And you're going to go ahead and insert this hose into this location right here where that actually says anesthesia hose, and this says scavenger. So we're going to go ahead and put our scavenger hose right there and make sure that the scavenger hose is either hooked into our active scavenger interface here, or you can certainly use your F-air canister over here. But for this demonstration, we're going to go ahead and hook it here. Now, the 2018 AAFP feline anesthesia guidelines don't outright ban boxing cats. I think they were afraid to take that step. But they do say that if you must do this, please get it over as quickly as possible, meaning turn your oxygen flow rate up at 4 liters or more, turn your gas concentration up to 5%, and get them in and out of this box as quickly as possible. But again, at OVRS, induction chamber inductions for cats or small dogs is discouraged. Let's try to place IV catheters or do other injectable anesthetic techniques. And that concludes induction chamber use on an EVAD machine. To change the pony tanks on this machine, you always want to make sure that there's a new one in place. So if this one runs out, you do have a new one. These new ones are kept in the basement in the oxygen room. But what you will do to change the pony tank is the first thing you're going to need to do is make sure that it actually is empty. This needle is in the red, but the needle actually can go all the way down to that post, and there is quite a bit of use still to this machine. But I'm going to go ahead and show you how to do it for demonstration purposes. So you're always going to want to turn your oxygen off and go ahead and use your wrench that lives at this location. Then we're going to go ahead and push the action flush to bleed the system out. And then to change the tank, what you're going to do is just unscrew this right here, and that whole piece will come right off. And if you look carefully, you can see a couple of pegs on the inside there. And if you look on the side of your pony tank, you can see there is a hole and a couple of marks where this will fit in. There is usually also a washer that comes with the new tank, so please change these as you change your tank. In order to hook that back up, it's very simple. All you need to do is go ahead and line up the 3 pegs over that part of the oxygen tank and push it in there, and then go ahead and use this to tighten it right down on there. And then if this tank were empty, we'd go ahead and rip that off and label it as empty. But right now this one technically should say part full or in use. And that is how to change the oxygen. If you do have to take this one away and start to use this one, please bring up a new one from the basement so that it is ready right here in the spare spot.